Hello and welcome to your video lecture on Chapter 16, which is going to cover alterations in cognitive systems, cerebral hemodynamics, and motor function. So let's get started and first talk about alterations within the cognitive systems, and we'll focus on consciousness. So if you remember, consciousness is really taking place at the cerebral cortex here. When we slice the brain, we're looking at that gray matter lining on the outside of the brain. And consciousness is our state of awareness. And that is going to include ourselves and the environment. And there are really two distinct components of consciousness. We've got arousal as one of them, which is our state of awakeness and alertness, and it's mediated by RAS, which is the reticular activating system that moves through the brainstem and then will send out signals all throughout the cerebrum. And the other component is going to be awareness. So awareness encompasses all of our cognitive functions, and it's helping to mediate by our attentional systems, memory systems, language systems, and executive systems. And I really like this graphic over here that shows you with normal consciousness, we have both high arousal and high awareness. When one is in a coma or asleep or has anesthesia, they are going to have both low arousal and awareness. And sometimes people who are in a vegetative state, unfortunately, are going to have low awareness but high arousal. Now, sometimes, as we said, we can only have alterations in arousal, and so we can classify these as a structural type of alteration. So if it is supratentorial, then that means the effect is taking place above the tentorium cerebelli. Do you all remember this dural fold here? It was the one that created a tent over the cerebellum that lies within this posterior cranial fossa. So really, it's within the cerebrum. And this is going to produce changes by either diffuse or localized dysfunction. So this could be caused by disease processes that affect the cerebral cortex. Let me go back a couple slides really quick. So we're talking about, again, that gray area over here, or it's going to deal with the subcortical, this white matter right along in here. Now in a minute, I'm going to reference the thalamus and the hypothalamus. So just to refresh your memory, that's this area over here. Oh, I'm going a little ahead. So those are the areas that are really affected with diffuse dysfunction. Now, we can also describe this as being extracerebral. So that means it's outside of the brain tissue. So we know that the brain is going to kind of sit along in here, and then we've got some spaces right along it. And so causes of this could be a neoplasm or closed head trauma with some type of subdural bleeding or accumulation of pus within the subdural space. So hopefully you remember all those spaces, and if not, I would revisit chapter 14. Another way we can classify it is that it is intracerebral, intra referring to inside. So we find this within the brain tissue. And this can more lead to localized type of dysfunction. So a mass that is causing bleeding within the brain, infarcts, emboli, or tumors. And this can directly impair what I pointed out before, the thalamic and the hypothalamic activating systems. And of course, if we have a supratentorial classification, we have to have a infratentorial classification. So infra referring to inferior, so it's going to be below the tentorium cerebelli as far as where the cause is. And this can cause a decline in arousal due to a destruction of RAS, the reticular activating system. Remember, that is kind of moving throughout the brainstem and then sends signals around the cerebrum. And so examples of what could destroy this area are demyelinating disorders such as MS, or accumulations of blood or pus in this area, or growth of tumors. And because RAS goes through the brainstem, destruction in any area within the brainstem can also cause issues. Two other ways we can classify alterations in arousal is metabolic. This means that we start to see an alteration in the delivery of energy, and this is seen when we are lacking oxygen. So hypoxia, any electrolyte disturbances, or hypoglycemia. And the other classification is our psychogenic, meaning we've got unresponsiveness taking place, and we could do a neurological exam to see if we've got normal responses taking place. So that could signal for us maybe a psychiatric disorder. And even though the person is unconscious, the person is still having those physiological processes functioning. So like we said, the neurological exam is going to give normal responses. Now, when we're going through the process of evaluating somebody for any alterations in arousal, there are these couple different pieces that we want to be functioning properly. And one of them is going to be the level of consciousness. And this is the most critical type of evaluation that we can give. So of course, first would be full consciousness. You're awake, alert, and ready to party. And I like this graphic because it kind of relates it to real life situations here. This also means that you are orientated to yourself, other people, the place you're at, and the time. So you're using your full cognitive capacities when you're fully conscious. The next step is confusion. And here you can't really think properly or very quickly, clearly, and are having a hard time making certain decisions. So you might be in this agitated state. You might forget things. And even when somebody gives you simple directions, you have a hard time following them. Now, this depiction did not include disorientation, but I want to give a little chat about this level of consciousness. This is when we start to see the beginning of a loss of consciousness. You become restless, you have anxiety, you're irritated, and first, you start to lose your sense of time. Second, you don't know where you are as far as location or recognize certain family members. You may even have impaired memory. And then the last step here is that you have a hard time recognizing your own self. Then as we go in deeper, you can fall into lethargy. And this is going to be when you are alert and you either may or may not be orientated to yourself, other people, your location, or the time. And you're moving very slowly, kind of sluggish, I would say kind of like a sloth. And you're falling asleep, but once somebody's trying to kind of like shake you or wake you up, you do wake up. So this graphic is saying you in college, we were all kind of sleep deprived, so we would sleep when we can, right? Then we have obtundation, and this is when we are extremely drowsy, we don't really respond. It's really on a scale from mild to moderate reduction in arousal. And you give answers to questions with a minimal response, kind of like, yeah, and it's going to require, if we fall asleep, rigorous stimulation to wake that person up. So they're not staying awake too long. And then we can enter the phase of stupor. And this is a deep sleep. The person is really only opening their eyes with you really vigorously and like calling their name, trying to wake them up. And so we often see that they are withdrawing. And even if they wake up, they kind of rapidly fall back asleep. Your book then takes coma and breaks it down into a light coma, coma, and deep coma. So when one is in a light coma, it really means that they are going to only have purposeful movement when they're stimulated. Whereas in a coma, we are going to go in a little bit deeper. So they have unpurposeful movements only on stimulation. And with a deep coma, there is no response to any type of stimulus at all. So next we have our pattern of breathing, and we're focusing on the rate, rhythm, and pattern of that breathing here. Normally our cerebrum, this area over here, is going to have a neural center that's going to produce the rhythmic pattern for us when we're conscious. And when we start to lose that consciousness, then it's areas within our brainstem that are really going to take over that breathing process. So we can classify these breathing classifications into two different types. We'll start with hemispheric breathing, hemispheric breathing. And so the first one is going to be this post-hyperventilation apnea. If you've heard of that term apnea, you know that it means that they are stopping their breathing. And so in this condition, we're going to have a patient kind of go through hyperventilation and then stop. And this is basically happening because the body is trying to control the carbon dioxide levels. So we've got respiration stops after the hyperventilation. So we can take this instance over in here. And at this point, because we've hyperventilated, we've pushed all of that carbon dioxide out of the lungs. And so now we have lowered carbon dioxide. And so the body is going to try and stop that breathing to hold on to the carbon dioxide. And then the hyperventilation is going to start to happen again once our CO2 levels go back up. So this typically happens due to diffuse bilateral metabolic or structural disease of the cerebrum. The way that it's going to sound in your patient is kind of like this. Okay, you can hear that apnea when I stop breathing. Next, we have our Cheyne-Stokes breathing, and this is kind of an interesting pattern because we're going to start to see that there's a smooth increase in the breathing. This is called the crescendo in the rate, and then it's going to come back down. It smooths down as we call it a decrescendo, and then there's a period of apnea. But while they're breathing, as far as the depth, it is going to be a hyperpnea. So the way that this is going to sound is kind of like this. And you may even hear this type of breathing in someone who's experiencing cardiac insult, such as heart failure or myocardial infarction. But in us talking about the brain, that bilateral dysfunction can happen in the deep cerebral area or even in a diencephalic structure, so like the thalamus and the hypothalamus. And we could see it in supratentorial injuries, which makes sense because that's the area of the cerebrum and the diencephalon, and metabolic induced coma states. Now that we've talked about the hemispheric breathing, let's start talking about some of the brainstem breathing patterns. So notice how we have the cerebrum up here, but over here we're just focusing on the brainstem at these levels. So let's talk about the central neurogenic hyperventilation, which is going to affect the upper pons. And this is going to be kind of what you see right over here. It's a sustained, deep, rapid, regular type of breathing pattern because at this point we have decreased carbon dioxide levels. So it's going to be something like this. Okay, very rapid. And we will typically see this in people that have damage to their central nervous system or have a disease that's involving the midbrain or the upper pons. And we see it also when somebody has intracranial pressure. It could be due to an increase in fluid or tumor or whatever causes that increase in pressure, and blunt head trauma. Next, we have our apneustic or apneusis type of breathing. This is going to be an area in which the middle pons is affected. And we see in the rhythm here that we've got this prolonged inspiratory breath in, and then they're going to hold it for about 2 to 3 seconds. And then it's going to be a brief expiration that takes place. And then the deep inspiration takes place again, and the cycle just repeats itself. So this is going to be caused by some type of damage to the respiratory control mechanism that we have in the pons. It could be due to a pontine infarction or someone who's documented with hypoglycemia, anoxia, and meningitis is another possible cause. Basically, they're having a lack of input from that vagus nerve that is creating the difficulty within the signaling here. And so the way it would sound is something like this. Something like that. All right, let's move on into cluster breathing. We will have a disordered sequence with irregular pauses between the breaths. So we're not going to really be able to have a rhythmic rate, let's say. It's caused by dysfunction in the lower pons, and it could also be damage to areas high within the medulla. So notice how this is going to look somewhat similar to our post-hyperventilation apnea or even the Sheen-Stokes breathing. But like I said, it's irregular, so you're not sure exactly how many breaths they're going to take and then have that pause of apnea taking place in between. So it would sound something like this. So more irregular here. And then lastly, we have ataxic breathing, and this takes place when we have damage to the medulla. It's completely irregular breathing. The rate is usually pretty slow, so you can kind of see that we don't have the waves quite as high over here. And it's typically going to be caused by some type of primary dysfunction of the neurons within the medulla that are helping to control that breathing. So it's something like that. All right, next let's talk about pupillary reactions. And I don't have a ton to chat about right here. Really, it's going to affect our oculomotor neuron, of course, which is cranial nerve number 3. We can have severe ischemia and hypoxia that could cause some type of dysfunction to the tectum or the roof within the midbrain that could cause one to have these large fixed pupils going on. And then if we have large doses of atropine or scopolamine that are drugs that are blocking our parasympathetic stimulation, we can also have fully dilated and fixed pupils. So as we know, oculomotor neuron has the parasympathetic fibers in there that is going to cause the pupil to constrict. So we have nothing to kind of combat that when we're taking these types of drugs. When we have diencephalic dysfunction, again, areas of the thalamus or the hypothalamus, we can have small or reactive pupils like this. Also, opiates can cause pinpoint pupils, and severe intoxication through barbiturates may produce fixed pupils. We can also have this one dilated pupil here if we have dysfunction of our third cranial nerve. And if we have just midbrain dysfunction, we can cause a mid-position and fixed look to our pupils. Another way we can evaluate consciousness is to look for oculomotor responses. So in addition to the oculomotor nerve helping to constrict the pupil, it is also going to give motor function to a lot of our extraocular muscles. And so we can use this type of testing for the oculomotor responses to see if there's any deficits taking place. So the responses could be resting, spontaneous, and reflexive eye movements. And people who are within a metabolically induced coma typically are going to keep their ocular reflexes, even though there might be some other type of brainstem damage taking place. So if we look over here at, oh, there's my mouse, at this test that we're doing, this is a test for the oculocephalic reflex response. This is also known as the doll eyes phenomenon. And so here we're seeing a normal response, right? They're looking forward, and then when we turn their head, notice how both eyes are working together in order to look at the center area here at the, let's say, the evaluator. And then same thing if we turn their head over to the left. Their eyes are both moving synchronously to look at the center area. Then let's take a look at an abnormal response here. So looking straight forward, that is fine. But when we turn their head to the right, notice how their eyes do not turn in a conjugate manner. So we're having this eye kind of functioning properly here, but this eye keeps that gaze in the other direction. And same thing when we turn the head to the left, where we are having this eye kind of going back to that center evaluator area, but this eye keeps that forward gaze along with the head. And then here at C, we're seeing that there is an absent response. So the eyes, again, centered over here, but when we turn their head to the right, the eyes are just staying along in the direction of that head movement. So they're just kind of staying centered. And same thing when we turn the head to the left here. And this is really depicting for us a brainstem injury. Now, in order to test the oculovestibular reflex, they do something called a caloric ice water test, in which they're going to take this syringe here and fill it with ice water. And it sounds kind of painful, but they inject it into the ear canal. And so a normal response is to have the conjugate eye movement take place. So notice how both eyes are going toward the side of the syringe here. Whereas an abnormal response, we see that there's disconjugate or asymmetric eye movements taking place. This one's going in the opposite direction and this one is the gaze forward. And then here at C, we are seeing there's an absent response, absolutely no eye movements taking place. Lastly, we can check for motor responses to determine the side of the brain that is most damaged. So in A here, we are taking a look at the grasp reflex. Now we have the grasp reflex when we are an infant. If someone puts their finger in our palm, we grasp it. And so we do not want this reflex in place as an adult. That would be more of a pathological response. Another reflex we see pictured here is going to be the snout reflex. And this is basically when you kind of do a light tapping near the closed lips in the area of the midline. And what happens is it causes a contraction of the muscles and the mouth starts to resemble a snout, or they do kind of a pout with the lips. So if that's present, that really shows us there's some type of brain damage or dysfunction taking place. That should, again, disappear in infancy. Another interesting one is the palmomental reflex, in which the person here is taking a key and stroking the area of the thenar muscle group, the thenar eminence is what we call it, at the wrist, and it moves up to the base of the thumb over here. And so if this reflex is present, then we get an ipsilateral contraction, meaning if we are stroking the, let's say, right thenar eminence, then the left side of the body is going to have this reaction where we get a contraction of the orbicularis oris muscle and the mentalis muscle. So the muscle surrounding the mouth and the area of the chin. And so the skin over the chin is going to wrinkle and the corner of the mouth is going to elevate slightly, which I don't think is too well depicted in this photo, but that's kind of what's supposed to happen. And then we, of course, have the sucking reflex too. This, of course, is present for a baby to get ready to suck in order to obtain its food, its milk. So that reflex is supposed to disappear in infancy. But with any damage to the brain, we know that these reflexes just are actually taking place. The last type of motor abnormality that we might see are these two positions that you see pictured over here. So with this first one, we call this decorticate posture or response. And this is when we have a flexion of the arms and the wrists and even the fingers. You can see them curled in under here with a deduction of the upper extremities. So see how she's holding her arms close to her body. And we will see extension taking place in the lower limb. So we'll see more of an internal rotation. You can kind of see that a little bit easier at the end here, and also plantar flexion. So remember, that's when your toes are kind of pointed down like a ballerina taking place. And so when we see someone in this position, it should signify for us that they're having some type of hemispheric damage above the area of the midbrain, and it's really affecting the reticulospinal systems. We didn't have too much of a chance to talk about this reticulospinal tract within AMP, so just to give you an idea, this tract is going to help to control any type of proximal and axial muscles that are involved with gross movements. So things like locomotion and posture. Now, the other position that we see here is going to be the decerebrate posture or response. And this is where all four extremities that we see here are in a rigid extension position. We also will have hyperpronation of the arms. So you can see they're almost very internally rotated. And we still have that plantar flexion of the feet. So this position is signifying for us that there's severe damage involving the midbrain or the upper pons. Here is a question for you. A patient has a structural problem within the brain tissue that decreases the level of consciousness. Which of the following terms best describes this location? The key here was within the brain tissue. And so if you answered intracerebral, you are correct. We know that subdural means that it's going to be below the dura mater, and infratentorial, we know it's below the tentorium cerebelli, and extracerebral means that it's outside of the brain tissue, which we know it's within in the question. All right, now let's talk about brain death or total brain death. Our brain can no longer maintain the internal homeostasis, and unfortunately, this is irreversible. So here's the criteria for brain death. We have completion of all of the appropriate diagnostic and therapeutic procedures. They're unresponsive within a coma. There's no spontaneous respirations taking place, no functioning of the brainstem. And then here you can see an EEG in which the brain waves are just completely flat. And then we have persistence of signs for appropriate period of time. And I think this appropriate period of time does change depending on where you're practicing, but they do look for an EEG that is flat for about 6 to 12 hours in a person who is not hypothermic. Next, let's talk about cerebral death, which is going to be different from brain death. This is an irreversible coma, and we're having more death of the cerebral hemispheres that is exclusive of the area of the brainstem and the cerebellum. So we don't see any behavioral or environmental responses here, and our brainstem can continue to maintain the internal homeostasis. When we have survivors of cerebral death, they remain within this coma and they are in a persistent vegetative state. So that's what we're seeing over here, is that cortex being affected here, but our brainstem and the cerebellum is just fine. That RAS that's going through here, reticular activating system, is also okay. And this can progress into a minimally conscious state, or MCS, or people go into what's called locked-in syndrome, which could be caused by brain damage, or I shouldn't say brain damage, but damage to the brainstem. This could be due to a stroke or a tumor, or people who are suffering from ALS, and the person can't speak or show facial expressions. Largely, people with this condition communicate with their eyes, moving their eyes around, and they can fully understand what somebody is saying or reading to them. They have that full cognitive ability. So something that's interesting that I just saw in the news recently is that researchers from the University of California, San Francisco, developed a new way for people to communicate and show facial expressions through the use of a brain implant and a digital avatar here. So this locked-in syndrome patient's name is Anne, and the implant can record neural activity from her cortex as she's trying to speak, and it directly translates those intended words, bypassing her paralysis, and will have the avatar speak for her. So that's pretty amazing. Now let's shift into alterations in awareness. And first we'll focus on selective attention. And in order to have awareness, this is going to encompass all cognitive functions. So when we have selective attention, this is really us just focusing on specific things, right? So it's our ability to concentrate on a specific task without being distracted. As my phone is dinging right now, right? We have so many distractions within our world. And so it is even harder nowadays to have that selective attention. We can also have selective visual attention where we are looking for something specific, right? So if you are given a task to, amongst all these different shapes, I need you to find a square red object. Or we can have selective auditory or hearing attention. I always kind of talked about in class how I actually cannot focus when it's completely silent. I need some type of background noise. So it'd be like me sitting down trying to listen to a lecture in a busy coffee shop, right? There's so much other noise going on, but I'm focusing on the voice within the lecture. And so to do this, we're going to include a lot of different cortical areas, our thalamic nuclei, and our limbic system. And of course, there's a ton of research being done for selective attention deficits. These can either be temporary, permanent, or progressive, and there is a broad category in which this takes place. It could be parietal lobe contusions. It could be someone suffering from a stroke. It could be someone that has late onset Alzheimer's, dementia, and psychotic disorders as well, even people that have seizure activity going on in their brain. But we'll save more of a conversation about this topic at a later time. So let's move on into memory. So just talking about memory in general, as you use it, we're always trying to hone in on how can I make my memory work better, right? It's the idea of us being able to record and retain and retrieve information. Just as you're listening to this lecture, we are taking this in and you're putting this information into what's known as your working memory or short-term memory. And this area of our brain just keeps this information long enough so we can make a decision or complete a task. And by making a decision, sometimes we're deciding, is this information important enough to put it into long-term storage, right? And how can I remember it? So it lasts from a few seconds to a few minutes. Then when we maybe have repetition of this information or deem it really important, when we go over it again and again, we are moving it closer to our long-term memory storage. And that it can be indefinitely placed within the long-term storage and also last a lifetime. And the more that we go in to retrieve that information into our memory, the more it will stay within our long-term memory storage. Now, when we have issues with our memory, it can cause amnesia, meaning a loss of memory. And this could either be retrograde or antegrade. You could see from this image over here, we'll talk about retrograde amnesia first. So if we have some type of injury causing that amnesia, what we are able to do with retrograde amnesia is be able to create new memories, but we have a hard time retrieving or recalling our past personal history memories. So things like riding your bike for the first time, or your middle school graduation, or your prom, or maybe you moved about 2 years ago and you can't remember your address. And then we have antegrade amnesia. When we get injured, that may cause us to have an inability to form new personal or factual memories. So if you meet someone and then a couple minutes later you forget that you ever met them. So it's kind of like that 10-second Tom type of situation. And you are able to hang on to those memories from your past though. Like we said, your prom or your high school graduation, whatever it is. And then we have global amnesia, and that is a combination of both anterograde and retrograde amnesia. So they have a difficult time remembering where they are, how they got there, who they are, when they were born, or even knowing their friends and family. And we may see this happening as dementia progresses, which we're going to talk about later on. Lastly, we have image processing, and this really is going to be a higher level of our memory's ability to function correctly, where we're integrating sensory data and language to form bigger concepts, to make abstractions. We're also going to be able to reason. And so when somebody has issues with this imaging processing taking place, they are going to have a hard time with abstract thought. For instance, the phrase walking on eggshells, they're going to literally think you are talking about walking on eggshells rather than the true meaning of when somebody says that, being overly careful when you're dealing with a person or situation. And this condition could be temporary or permanent depending on what type of injury the person sustained in order to have this image processing issue. Whenever we have an executive attention deficit, it means that we've got an inability to maintain sustained attention and a working memory deficit. I know that I've worked with some students, especially with these tough anatomical terms that we have to use, where I will go through and teach them 2 terms and they have difficulty even recalling them about, like 15 seconds later. So it's really that working memory that is a deficit, and then they have a hard time moving that into more of their long-term memory storage as a result, of course. So we're going to talk about ADHD more here, which stands for Attention Deficit Hyperactivity Disorder. And this is a common disorder of childhood that can continue through adulthood. And what they've now recognized is that about 50% to 75% of people who are diagnosed with this have it continuing into their adulthood. So they still suffer from some of the symptoms, which make it very difficult to function at work, at home, or in social situations. And this is because they have issues of inattentiveness, hyperactivity, impulsivity, and problems with their executive functioning. We're not exactly sure of the full pathophysiology of this, but through certain imaging, we were able to know that it involves some type of developmental abnormality of brain networks that are related to cognition, attention, emotion, and sensory motor functioning. Now, there are some medications that can help to regulate this, but of course, it's going to be a little bit different for everyone. There's different levels, let's say. Continuing our discussion on disorders of awareness, what the pathophysiologic mechanism here are through really 2 main mechanisms. We've got direct destruction caused by some type of ischemia and hypoxia, or indirect destruction caused by compression. And the other is an effect of a toxin, chemical, or a metabolic disorder. And one of the things that we see is actually a parietal lobe disease that can produce a unilateral neglect syndrome, or basically where we have a lack of awareness of the one side of our body and we're lacking a response to stimuli on that one side. And this can occur after a stroke. So if you see someone that has suffered a stroke and they maybe have only groomed themselves on one side, or like dress one side, eat only on one side of their plate, chances are they have this unilateral neglect syndrome. And so what can happen is a person with this type of syndrome can recognize sensory input from the dysfunctional side when they're asked. So I want you to draw your attention to this image down over here, where the practitioner is going to hold up their fingers and then is asking the patient to point to the fingers that are moving. So you can see here that this person is not having an issue pointing it out here on the practitioner's right side, and then they can point it out on the left side. But then when the stimuli is coming in from both sides, they tend to favor the side that is functioning correctly, meaning that they are ignoring the sensory input from their dysfunctional side when they're stimulated from both sides, and this is known as extinction. And then so within this neglect syndrome, what we tend to see is that patients will neglect or ignore one side of things. So you can kind of see where the patient here is trying to replicate these drawings. They're missing it over on the left side. Same thing here when they were asked to draw a clock, or they might add more detail to the unaffected side here on the right. Now let's move into data processing deficits. This is when people have issues with recognizing and processing sensory information. First, let's talk about aknosia. This is a defect of pattern recognition, meaning that they're unable to recognize the form and nature of an object. And this could be tactile, visual, or auditory, but usually it's only one of these senses that are affected. So someone might be unable to identify a key, let's say, just by touching it with their hand, but they're able to name it when they are looking at the key. Another example would be if they were provided a model drawing, they're able to replicate by drawing the lines and creating the same drawing of the objects, but then when they have to identify that object, they are unable to do it. And typically we see that people are affected this way due to cerebrovascular accidents, but it can happen from other pathological issues within the brain as well. Next, let's talk about some aphasias. This is when we have a defect of language comprehension or production, and it's usually, again, associated with a cerebrovascular accident, and we have some different types here. So before we get into the different types, I just want to mention that typically aphasia is going to deal with a dysfunction on the left cerebral hemisphere. And specifically, we've got areas that are affected the most, which would include an inferior frontal gyrus and a superior temporal gyrus, and the subcortical and cortical connecting networks that we have within these areas. So here you can see a couple of them highlighted. Essentially, these areas are being supplied with blood from the middle cerebral artery or its branches, and so that's why we see the effects in those areas. So let's move into the different types. First, we've got expressive aphasia, and this is also known, and I would like for you to know these names interchangeably, but it's known as Broca's aphasia as well, or motor or non-fluent aphasia. And so it's going to involve a loss of the ability to produce spoken or written language with slow or difficult speech. So you have a little cartoon, I don't know why it got cut off here, but they're having a difficult time expressing what they want to say. But through this, their verbal comprehension is present. This is going to be different from receptive aphasia, which I want you to know is also known as Wernicke's aphasia, sensory or fluent aphasia. This means that they have an inability to understand written or spoken language. So their speech is fine. Think of like their motor abilities are fine in saying the words. They're flowing at a normal rate, but what they're talking about does not make sense. They could put a sentence together like, dog went with the bowl to get a flower, or something like that. So the words have no meaning. It doesn't make sense. Our next one, transcortical dysphasia or aphasia, is rare, and it could be motor, sensory, or mixed, but it's going to involve some areas that connect to the language centers. So that's kind of why it's here. And then we've got global dysphasia, also known as global aphasia. Those terms can be used interchangeably, and this is the most severe kind that you could have. It is going to involve both expressive and receptive aphasia. So that's kind of why I put this picture here, because if we think of Broca's area, it really has to do with formulating those words, those motor patterns to get the words out. And then Wernicke's, of course, is understanding speech. So it's both of those that are affected, and it's going to make the patient non-fluent or mute. They are unable to read or write and have impaired comprehension, naming, reading, and writing. Continuing our discussion on data processing deficits, we want to talk about acute confusional states now. These are transient disorders of cognitive function, involve consciousness or perception, and they're going to arise from the brain networks, not a discrete area of the brain. Now, delirium is known as a subtype of acute confusional states, or ACSs, but most people will use them interchangeably. And essentially, these are states in which the pathophysiology here is a interference with neuronal metabolism or the synaptic transmission. And a lot of these conditions have to do with the neurotransmitters. So you'll see in a couple of the topics we're going to talk about that individuals will have decreased acetylcholine as a neurotransmitter and excessive dopamine. And there are two different types of delirium known as hyperactive and hypoactive, but some people can kind of go in between these two things. So that is called mixed delirium. So when we have a patient that is in the hyperactive state, so we call this hyperactive confusional state, we'll see that the autonomic nervous system is overactive, and it tends to take about 2 to 3 days to get all of these symptoms I'm about to describe happen. But patients typically that are in critical care units, or this may happen after surgery, or if they're withdrawing from our central nervous system depressants such as alcohol or any type of narcotic, will or not will, but may have this hyperactive state taking place. So they will be really restless, irritable, they'll have difficulty concentrating and will not be able to sleep. So they'll suffer from insomnia, and they may even have a tremor and have a poor appetite. You'll also see that they're flushed and will have dilated pupils, tachycardia, and an elevated temperature, which causes them to have profuse sweating. Whereas hypoactive states, known as hypoactive confusional state, is when we have an issue or a disruption within their right-sided frontal basal ganglion. So if you remember, the basal ganglion kind of helped coordinate movements, and we've got areas that are helping us with alertness. So those individuals that have high fevers or some type of metabolic disorder like chronic liver or kidney failure will experience kind of the opposite things. Opposite symptoms that we just talked about from hyperactive states. And also with the hyperactive state, we said that individuals that are withdrawing from the CNS depressants may have hyperactive state taking place. So, and the opposite view of this, we are going to see individuals that are under the influence of central nervous system depressants may experience hypoactive confusional state. So they would be kind of sloth-like, so very slow in their movement. They'll have decreases in alertness, and their attention span is really short. They are going to have a hard time interpreting their environment and reacting to their environment. They also might have forgetfulness or apathy, which, if you remember, apathy means a lack of interest or concern, basically not being very enthused. So in nursing, you can, of course, go through your nursing delirium screening scale and the confusion assessment method to kind of assess your patient. And ultimately, you want to treat the underlying cause that is making them either hyperactive or hypoactive confusional states. Individuals that are experiencing dementia may be more prone to having delirium take place, and dementia is going to be an umbrella term for these other conditions. So sometimes people will use dementia and Alzheimer's interchangeably, but they are two different, I guess, classifications of terms. So let's talk more about dementia next. This is our progressive failure of a lot of the cerebral functioning within the brain, including impairment of intellectual processes. And with that, we're going to see a decrease in orientation, memory, language, judgment, and decision making. And so as a result, we might see in these individuals that they have a alteration in their behavior. They might be more agitated or wander off, or might even become more aggressive and start swearing and things like that. So the mechanisms that could cause dementia to take place are neuron degeneration, brain tissue compression, atherosclerosis, specifically within the cerebral vessels, such as the circle of Willis, brain trauma, or it could be due to infection or neuroinflammation. And we know that there's also a possible genetic predisposition to that, and we'll talk about that as we get into the specific types of dementia. Here we see a comparison of also some of the clinical manifestations that we're going to see within these two different types of dementia. We've got Alzheimer's here, where women have more incidence of having Alzheimer's, whereas men are going to be at higher risk for Lewy body dementia. We see that there is a difference within the median survival age. And I'm going to talk more about these amyloid plaques and the tangles in the next slide. And this is the most common type of dementia. Now on this graphic, it does say that this Lewy body dementia is the second most common type of dementia, but it really is vascular dementia. So I want to give that little note over there. And it's caused due to this Lewy body protein that we have within the brain that builds up. So let's talk about Alzheimer's in specific, also known as AD. Like we said, that's our leading cause of severe cognitive dysfunction, dementia within older people. And we've got three different forms. So our first form is the non-hereditary sporadic or late onset dementia. And this is the most common. It happens in about 70 to 90% of all of the forms of AD. Next is going to be the early onset familial AD. That is going to be the second most common, and then the least uncommon or the rarest is going to be the early onset AD. Now we don't know the exact cause of AD, but we do know that both of the early onset AD and late onset AD are going to have some type of genetic association with that. With the early onset AD, it's linked to three different genes. You may have heard of some of these. One is known as APP14, another one is PSEN1, and last one is PSEN2. And for the late onset AD, and I feel like this is better known, it's going to involve a gene known as ApoE4, which I actually posted an article on this on Blackboard for you to read. Now let's take a look at some of the pathologic alterations that we have within AD. We are going to get a development of these neuritic plaques that develop, and in these plaques they're going to contain a core of amyloid beta protein. And we'll also see we've got these neurofibrillary tangles that are of the tau protein, which you see a picture of over here. So notice how we've got both of these going on here in Alzheimer's disease. And essentially what is supposed to happen is we have some neuroglia cells that will go in and clean out these plaques. This is always happening. It's even happening in your brain right now. And those microglial cells are really active when we're sleeping. So that's why sleep is so important to our health. They will help kind of clear out what I call the garbage sitting in between the neurons here. So with the plaques building up, it's actually kind of blocking or disrupting the nerve signal from going from one neuron to the other. And so when we keep blocking these signals, we start to get these neurons dying. And this happens to be concentrated in the area of the cerebral cortex and the hippocampus, which is so important in memory. So we get a loss of these synapses, a decrease in acetylcholine. And so with all this blockage, I'm going to go to one slide before, we are going to start to see that the brain tissue is going to start to atrophy. So we see bigger gaps within the sulci and an overall atrophy of the tissue, a shrinking of the gyri here, and larger ventricles than we need. So of course, with the shrinking of this brain tissue, which yes, it does take time for it to take place, it's progressive, but early on we'll see that the person will have more forgetfulness taking place or will become more emotionally upset. And over time, they'll get memory loss, disorientation, confusion, lack of concentration, a decline in abstraction, problem solving, and judgment. I know this past summer I went and visited my grandmother who is, dealing with this, and she asked me many times where I live because she lives in California. And also she kept asking my children what grade they were in. She even started talking about her mother, did you go and visit my mom? And I was like, yes, I went and saw your mom, just not to upset her. So how do we go about diagnosing this? It's essentially a process of elimination by ruling out other causes of dementia. We can't really see these plaques and tangles until after the person passes on and they do a scan of the brain to look for these plaques and tangles. But of course, if we have neuroimaging and we're starting to see these bigger gaps between the sulci or the ventricles enlarged, that's a pretty clear sign of what's going on here. There are some efforts in process to look for some biochemical markers to help with the diagnosis process. So hopefully we can even get some predictive biomarkers of things like the tau protein or these amyloid beta peptides, and our apolipoprotein E4s that can kind of give us a clue as to what is taking place, and we could do things to stop this disease from progressing. Next up, we've got vascular dementia. This is going to be the second most common cause of dementia, as I said before, and usually the cause is due to some type of cerebrovascular disease. So something associated with large artery disease, cardioembolism, small vessel disease of the brain, and stroke. All of these are going to cause hypoperfusion in the brain, and we do see that it is more common in men. In order to treat this, they work to prevent risk factors such as developing diabetes, hypercholesteremia, hypertension, or if the individual is smoking, we obviously want them to stop. All right, let's go to frontotemporal dementia. And this is going to be also known as PIC disease. This is a rare degenerative disease and is going to deal with the degeneration of the frontal and anterior frontal lobes. And there is a familial association with an age of onset less than 60 years old. So we've been talking about the tangles and the tau proteins. Within this type of dementia, we see that there is a gene mutation specifically on the tau protein. You can see in this image down here that we have most of the tissue that's affected is in the frontal and the temporal areas. You can see in this image too how we do have a shrinkage of the brain tissue in those areas as well. And unfortunately, there is no specific treatment for this type. Now let's get into the topic of seizures. These are just manifestations of disease and not a disease itself. And it's going to be a sudden transient alteration of the brain function caused by abnormal excessive discharges of the cortical neuron. So you can see pictured here is a neuron from the brain. And when you hear the term epilepsy, this is really a disease of the brain of these recurrent, unpredictable seizures taking place. And so you can utilize the term convulsion when talking about seizures because within that process that's taking place, the individual tends to go into these tonic in which the individual is going through jerky contractions and then relaxation movements. And so, like I said, you kind of see these within seizures. And you could see here pictured is the tonic phase and then the clonic phase. So let's go through some of the associated conditions that can cause a seizure to come on. They could be metabolic disorders, congenital malformations. There could be a genetic predisposition, prenatal injury, or postnatal trauma, myoclonic syndromes that can cause an involuntary jerking of muscles, any infections, brain tumor, vascular disease, and substance abuse, whether they're drugs or alcohol abuse. There could also be certain conditions that cause a seizure to come on, such as people that may have lowered blood sugar, fatigue, having a lack of sleep, emotional or physical stress, fever or large amounts of water ingestion, constipation, or use of antipsychotic drugs, especially when used with alcohol, and having withdrawal from depressant drugs, or having an individual hyperventilate. Also, some environmental stimuli might bring it on, such as blinking lights or loud noises, certain odors, and women tend to have an increased risk immediately before or during their period. And we have many different types of seizures, so we classify these based on their clinical manifestations, the site of origin, EEG correlations, and a response to therapy. So like I said, we have many different types of seizures, but we're going to focus on these three listed here. So focal seizure, first known as a partial seizure, is going to originate just in one area of the brain. And sometimes they have a aura, which is kind of a undescriptive feeling of knowing a seizure is about to come on. The best way I can describe that feeling is kind of like that deja vu feeling, but just knowing that a seizure is coming on instead. And there are many different subtypes too. For instance, involving the motor functioning, we can have a tonic focal seizure where we've got stiffening of the body muscles with falling, loss of consciousness. It can occur within their sleep, and it is more common in infants and children. And we've also got the non-motor, which could involve something more sensory, where they tend to get numbness, tingling, or burning sensation, flashing lights, or auditory experiences. It could also be more emotional, where they feel fear, agitation, anger, crying, laughing, or paranoia. We've got the tonic-clonic too. That is a loss of consciousness. The body can stiffen up, being the tonic portion, and then result in shaking. That's the clonic moment where we're relaxing and contracting again. And it may begin with sudden crying, sometimes a loss of bladder control or biting of the tongue. It usually lasts about 2 minutes. And then there's confusion, agitation, and fatigue. And we do see that headaches and soreness are more common after the episode. Generalized onset is going to involve, of course, our seizures in both sides, general meaning an area, right? All over. And so this can happen simultaneously on both sides and can include tonic, atonic, clonic, myoclonic, myoclonic, atonic, clonic, tonic, clonic activity, which overlaps with the focal onset versions of these. And then lastly, we've got our epilepsy syndromes. And these are going to be displayed by a group of certain signs and symptoms that are occurring at the same time, and they help to characterize this particular condition. Now let's get into some of the pathophysiology when it comes to seizures. We enter this preictal phase first, in which there are 2 symptoms that signal the seizure. So first we have a prodroma, and this takes place about a few hours to days before the seizure takes place, where they are getting some feelings such as anxiety or depression, and they are not able to think clearly. And I've got a little bit of a description here for you. And then we've talked about an aura before too, which takes place right before it. It's a strange sensory experience in which right after the seizures, well, the aura takes place right before the seizure comes on. This, of course, can become really helpful for the person that is having seizures happen to them, so they can maybe lay down or prevent any type of injury that could take place while they're experiencing the seizure. Then we have ictus, which essentially is while the seizure is taking place and having that tonic-clonic activity. You may even have some relaxation of the urinary and bowel sphincters that could cause incontinence to take place. Airway maintenance needs to be ensured. And then we have the post-ictal state that can take place. Like we said, following a seizure, we tend to see that there's higher incidences of things like headaches, confusion, dysphagia, memory loss, and paralysis. And this can last anywhere from a couple hours to a day or two. And lastly, we have status ellipticus, which is when we have an adult that is having a continuous seizure lasting more than 5 minutes, or they're having the seizures taking place back to back pretty rapidly before the person is able to regain their full consciousness from the seizure that they just experienced. So this can last anywhere from 30 minutes or more. Now we're going to shift gears and talk about alterations in cerebral hemodynamics. So what this means is that we have a primary brain injury that is going to lead to a secondary brain injury because of cerebral blood flow alterations, intracranial pressure, which is what we're going to talk about first here, and oxygen delivery. So first, let's talk about these increased intracranial pressure issues, and we abbreviate that as IICP, and this can result from an increase in intracranial content that is occurring due to a tumor growth, cerebral edema, excessive cerebrospinal fluid, or a hemorrhage taking place. And we need to essentially get rid of this pressure so that we can maintain cerebral perfusion. So normally the pressure, the intracranial pressure, is going to be 0 to 15 millimeters mercury in adults. And if the pressure is increased in there, then we are going to start to experience some clinical manifestations, which we can see pictured over here. So one of the earliest signs is drowsiness. Then it could be followed with a headache, nausea, vomiting, and an altered level of consciousness. And of course, we can lead to other clinical symptoms depending on where the buildup of pressure is, right? It depends on kind of what the main cause is. So if we have something like a tumor or edema building up, it could cause compression of our midbrain and brainstem structures associated with a rapid neurological demise. If we have enough pressure in a certain area, we might also see some herniations taking place, which means we get a protrusion of brain tissue through an opening in the supporting dura of the brain. So to keep continuous evaluation, there are 4 progressive stages of increased intracranial pressure. In stage 1 of intracranial hypertension, we will have vasoconstriction and external compression of our venous system so that the body is basically trying to decrease the intracranial pressure at this point. And so we might not even see any changes as far as the 0 to 15 millimeters mercury at this point because the body is compensating and keeping the pressure at a maintain or homeostasis level, right? So there may be no detectable symptoms at this point. But then as we start to increase the pressure, let's say the volume of fluid or the tumor is growing, then we can have more difficulty in compensating. And so we start to experience decompensation. And so we have difficulty staying awake. Remember, we said one of the first signs is drowsiness. We can have small reactive pupils and normal or slow breathing. And you could see as we move further into decompensation, we are changing those levels of breathing that we had talked about at the beginning of this lecture. And herniation can take place at stage 4. And at this point, with that herniation in place, we are compromising the blood supply, and so we can have further ischemia and hypoxia in those herniated tissues, and this can really impair vital cardiovascular and respiratory regulatory centers and cause death with herniations in the area of the brainstem. Now let's talk about cerebral edema, which of course can cause an increase in intracranial pressure, but describing cerebral edema itself is when we have an increase in fluid, whether it's intracellular inside the cell or extracellular within the interstitial tissues of the brain. And we've got 3 different types. First is going to be the vasogenic edema, and this is the most clinically important, so know this one well. It is the more common type. And so here we will have an increase in the capillaries' permeability, and so that compromises the blood-brain barrier. So when that's compromised, it allows the plasma proteins from our blood to leak into these extracellular spaces, and that increases, let's say, the osmolarity here, and it's going to draw in the water. Remember, water wants to go where there's a high concentration of solutes, and this is basically taking place in the area of injury, and that could be due to some type of trauma, infection, a hemorrhage, tumor growth, ischemia, infarction, or some type of hypoxia taking place. So as the fluid is building up within that area, we start to see patients having focal neurologic deficits, disturbances within their consciousness, and like I said, an increase within their intracranial pressure. So the treatment for this is hopefully through slow diffusion of that fluid back within the bloodstream, and I'll talk about some other treatment methods once we go through these other types. So next we have our cytotoxic edema, or this is also known as cellular brain edema, mostly because of the fluid that is going to be moving into the cells of the brain. And cells of the brain, we're talking about the neurons, the glial cells, and even the endothelial cells that are helping to create our capillaries, right? So at this point, our blood-brain barrier is intact, but we are starting to get an accumulation of toxins that is affecting the active transport system for these cells. So they start to lose their potassium, which we know we have a majority of it inside the cell, and instead they're gaining a lot of sodium. So more sodium is moving into the cell, and we know the rule, wherever sodium goes, water wants to go. So the water is moving into the cells, and the cells start to swell up. And this typically takes place in the area of gray matter, and we see this type more with head injuries, hypoxia, and arterial infarctions. Lastly, we've got our interstitial or hydrocephalic edema. This is called hydrocephalic edema because we tend to see this with non-communicating hydrocephalus, which we're going to talk about in the next slide. And this is when we have edema take place because of the movement of the cerebrospinal fluid. Remember that we have CSF within our ventricles. So here we see our lateral ventricles here, and they are going to move into the extracellular spaces of our brain tissues. So we also call this transependymal edema. Remember, those ependymal cells were the ones lining the ventricles, right? So that's where the name came from. And so how do we treat these conditions? We want to try and decrease that intracranial pressure until we get the fluid to diffuse into our cardiovascular system again, right? But we can also use oxygen or osmotherapy, using mannitol or diuretics. We can also place a cerebrospinal drain tube to get some of that fluid out and maintain their systemic blood pressure with fluid management. We may also give some steroids to treat the edemas that are associated with brain tissues, which is what we see over here. This is a MRI image, and we're looking at the area that is the parieto-occipital, that when we look at it post-contrast here, we can see that the edema, which we see in the darker color over here, is not going to be enhanced with the contrast that we place. So this here is going to be the tumor, and this is the edema that's associated with it. And down here we see brain edema. This is a coronal section, so you're kind of slicing your body from anterior and posterior, and it's demonstrating that we've got marked compression here at the lateral ventricles, right? They should be wider here. And so in looking at the gyri at the top here too, we can barely see any sulci here. So we know that there is bilateral cerebral edema since we've got that going on both sides. And like we said, this can increase intracranial pressure that can lead to herniation. Next up is hydrocephalus. With hydro, you want to think water. Cephalus is referring to the head. So this is when we have excess fluid within the cerebral ventricles, which you see pictured over here. The subarachnoid space, which is going to take that cerebrospinal fluid and place it into that space and kind of circulate throughout the meninges. And then it could also be both of these working together to cause the hydrocephalus. So this could be caused by an interference in the CSF flow, and that could be due to an increase in fluid production, an obstruction within the ventricular system that we see pictured here, or it could be defective reabsorption of that fluid to put it back into, like we said, the subarachnoid space, which then is going to move into the venous sinuses, and of course that brings all of that blood then down into the jugular vein to eventually enter the heart through the superior vena cava. So we can also have something such as a tumor of the choroid plexus. Remember, those were the plexuses within the ventricles that produce the cerebrospinal fluid. So if we have a tumor there, we start to get an overproduction of the cerebrospinal fluid that would lead to the increased fluid production. Now we have a couple different types of hydrocephalus. We've got our non-communicating hydrocephalus, and this is typically a congenital abnormality. Although you can get hydrocephalus from infancy all the way up to adulthood, typically it's identified at birth, but it can also be seen up to 5 years of age most commonly, especially in this non-communicating type of hydrocephalus. And this type is also known as internal hydrocephalus or intraventricular hydrocephalus. And essentially it is where we have an obstruction somewhere within our ventricular system. So then we've got that blockage, and of course the fluid is not moving through the areas and can start to sit within these ventricles and create pressure. Like we said, we see that more within children. Next up, we have communicating hydrocephalus, and this is when we have a defect of the reabsorption that we were talking about earlier. So the fluid is being produced, but then we're not taking it from the subarachnoid space and putting it into that venous sinus to kind of enter the cardiovascular system to take it back to the heart. And then we've got acute hydrocephalus. This is when we see fluid accumulating gradually, and then as that fluid is starting to increase, we are going to see signs of a rapidly developing increased intracranial pressure. And if we don't treat it, it can lead the person to go into a deep coma. Lastly, we've got our normal pressure hydrocephalus. So we will see this typically within the elderly. Remember, the non-communicating or what we also call congenital hydrocephalus, we find that within infants or children up to 5 years of age. But with this normal pressure hydrocephalus, we will start to see more of a dilation of the ventricles without seeing an increase of that intracranial pressure. So we'll see typically a triad of symptoms in the elderly. They will have an unsteady, broad-based gait, so they're kind of walking with their legs spread apart, and they may have a history of falling there. So that's the first one. Second triad symptom is going to be incontinence, and then third is they also have dementia. So how do we go about treating patients with this? Usually it's diuresis or a placement of what we call a ventriculoperitoneal shunt, essentially shunting the fluid from the ventricles into the peritoneal cavity in the abdomen. As far as other ways of evaluating and treating patients with hydrocephalus, for diagnosis, there's a physical examination that's done and also some imaging to see if there's dilation of the ventricles or some type of obstruction and so forth. We can also perform surgery depending on what the cause of the hydrocephalus is. Maybe there's a tumor or hematoma that has to be treated to allow the fluid to travel properly. or we could do a ventricular bypass into a normal intracranial channel. In other cases, we may choose to do an extracranial bypass. So essentially, this is a shunting procedure again. And for other situations, there might be some type of excision or coagulation of the choroid plexus. Remember, that's the plexus that creates CSF in order to reduce the amount of CSF production. So here's another question for you. A patient experiences edema in the brain caused by movement of cerebrospinal fluid from the ventricles into the extracellular space. What type of edema does this describe? If you said C, interstitial, you are correct, because that was caused by that epidemal movement of the CSF. Remember, the ependymal cells are lining the ventricles, and so it's going to move the CSF from the ventricles into the extracellular spaces of the brain tissue. Now let's talk about alterations in neuromotor functioning. So whenever we have dysfunction in our nervous system areas that are controlling movements, that can cause any of the following: alterations within muscle tone or muscle movement. We can have upper and lower motor neuron syndromes, motor neuron disease, and amyotrophic lateral sclerosis. So let's talk about each one of these individually, starting with alterations in muscle tone. So one can have hypotonia, which means decreased muscle tone, and this is with whenever one has passive muscle movement. So think about like if you've ever been stretched, right? Somebody's kind of moving your limb for you. That's what we mean by a passive movement. But there's little or no resistance. Usually in a person that doesn't have hypotonia, they're going to be able to have just a little bit of resistance. And sometimes the person's like, just relax your leg or whatever it is you're trying to stretch. And so this could develop because of some type of cerebellar damage, or something that's a little bit more rare is a pure pyramidal tract damage within the medulla. And so people that have this are typically going to become tired really easily or are weak. They may have difficulty rising up from a sitting position or have a difficulty using stairs. Their joints become hyper flexible and their muscle mass starts to atrophy because we're not getting enough input from motor units. So their muscles tend to become flabby and flat. And what's interesting is over time, those muscle cells are going to gradually start to become replaced by connective tissue and fat, which happens as we age anyway. We start to lose muscle, but it kind of accelerates that process. And you could see here in an infant that has hypotonia, how almost like limp-like they are. So next, let's talk about hypertonia, which is increased muscle tone. Within this, we'll have passive movements of the muscle, but there is resistance to the stretch. So it could be caused due to an upper motor neuron damage with a loss of that inhibitory control. And there are 4 different types of hypertonia. We've got spasticity, which is usually when we have an issue with our corticospinal tract. And we can see that taking place over here where we've got paroxysm of the left side of the face. We also see that in the image over here. If you look at the neck over here, this is a spasmodic torticollis. So whenever you hear that word torticollis, it's talking about the neck muscles becoming hyperactive and essentially causes the head to turn to one side more often. And you can also see that taking place over here. There's another torticollis. Another type is peritonia. Here we will also create resistance to a passive movement. And we're not exactly sure what the mechanism behind this is, but we do believe there's an association with the frontal lobe injury and can happen with progressive Alzheimer's dementia. Then we've got dystonia, And dystonia is when we have a sustained involuntary muscle contraction with some type of twisting movement. So you could see that really well in the images down over here. And it's really because we don't have that reciprocal inhibition of the muscle to be able to kind of put that area in a neutral position. And lastly, we have rigidity, and this tends to be an issue with the extrapyramidal tract. And to further subdivide this, there are 4 types of rigidity that are plastic or lead pipe, cogwheel, gamma, and alpha. So there is more information about those subtypes in table 16.17, so I would check that out. Now let's talk about some alterations in muscle movement. Whenever we see this word hyperkinesia, you want to think of excessive purposeless movement. And we've got many different types of hyperkinesias. For instance, tremors would be included in here, but we're going to start talking about dyskinesias. Paroxysmal dyskinesias are actually rare, but we see that they're episodic involuntary movements that occur as spasms. So you see that pictured over here at the top, and notice how he is kind of doing a twisting in movement. So typically these types of disorders involve some type of dystonia. They may also experience chorea, which is going to be an abnormal jerky movement. The word chorea kind of means dancing, so think of those types of movements. And then we have athetosis as well, that is more of a withering type of movement. And ballism is also typically present, which is more of a flailing limb type of movement. The next type is called tardive dyskinesia, and this involves involuntary movement of the face, lip, tongue, trunk, and extremities. You can kind of see an example of this over here, although we do see this occasionally in people that have Parkinson's. But what we tend to see is rapid, repetitive, stereotypic movements, such as protrusion or rolling of the tongue, sucking and smacking movements of their lips, a chewing motion. Sometimes we have a facial dyskinesia or facial grimacing, and involuntary movements of the body and extremities. Like we said, we can see this in Parkinson's, but typically we see it more as a side effect, let's say, of someone that has been using antipsychotic drug therapy for a prolonged period of time. Then we've got Tourette syndrome, and this is going to involve having some complex tics, compulsions, preservations, and mannerisms. So some of the tics could be motor in nature, meaning that they're going to be sudden, rapid, repetitive, non-rhythmic movements. It could be anything that's simple, such as eye blinking or grunting, to things that are more complex, like banging their head or repeating another person's words. There can also be vocal tics as well. Now, in order to treat this, the most common way is to do a habit reversal therapy, or there are instances in which deep brain stimulation are utilized as well. Another alteration in muscle movement is Huntington disease. We briefly talked about this in chapter 2. It is also known as Huntington chorea. And the reason we talked about it in chapter 2 is because it is a autosomal dominant hereditary degenerative hyperkinetic disorder. And so the way that this happens is that there is a abnormally long Huntington protein that is toxic to neurons. So what research has found is that the longer the repeat of the sequences within this protein, the more toxic it is, and so it kind of increases I shouldn't say increases the age, but it essentially becomes so more toxic, and the onset of the symptoms will happen at a younger age. So the greatest pathologic feature of Huntington disease is severe degeneration of the basal ganglia, and specifically the caudate nucleus, which we should find right within this area over here. And if you remember, that area really helped coordination of movement. So these tangles of Huntington protein start to collect within in the brain cells, and they're not going to function correctly. We also have a depletion of GABA, which is an inhibitory neurotransmitter. So with these things combined, it really starts to alter the integration of the motor and even mental function. So some of the manifestations that we see that you can see pictured over here are involuntary hyperkinetic movements, such as chorea, which is why it was once called Huntington chorea. There's also athetosis and embolism. And so with the chorea aspect, they're going to start to see more movement within the face and the arms that are involuntary, and eventually it starts to affect the entire body. They will start having difficulty swallowing and a loss of coordination. As far as the mental aspect of things, we do see that they may become depressed or have mood swings. There's also difficulty, cognitive difficulties, let's say, especially within learning and reasoning. So they have kind of more slow thinking, a loss of their working memory, and overall a reduced capacity to plan, organize, and sequence. And so because we have a reduction in that working memory, we can also have that memory loss taking place. As far as diagnosis, you take the family history and look for a clinical presentation, but of course with genetic testing, that will help to confirm the diagnosis. And unfortunately, there is no known treatment. Next, we have hypokinesia, and this is where we have a decrease in movement. So a loss of the voluntary movement, even though we have normal consciousness and a normal peripheral nerve within the body and muscle functioning. And if you've ever studied Parkinson's disease, which yes, we are going to talk about that next, this should look pretty similar to you because Parkinson's disease symptoms are the hallmark of hypokinesia. So there are different types of hypokinesia. We've got akinesia, which A means without, right? So this is a decrease in voluntary and associated movements. So we will have this caused by a deficiency of dopamine, or there's something that's causing a defective receptor for dopamine. So this occurs in Parkinsonism. And then we have bradykinesia, which is really a slowness of the voluntary movements. So they are going to really have a delay in the time that it takes to start or perform a movement. And lastly, we've got a loss of associated movement. And this is when we are losing the normal habitual associated movements that provide skill, grace, and balance to our voluntary movements. For instance, when we walk, let's say across a room, we are going to typically move our arms, right? We're going to get some arm swinging. So we're losing that within this condition. Also notice that we have an expressionless face and more of a statue-like type of posture and an absence in speech inflection. It's more of like a monotone type of speech and an absence in spontaneous gestures. As promised, we're going to talk about Parkinson's disease next, and this is going to be when we experience severe degeneration of the basal ganglia with a loss of dopamine producing neurons. Now I'm going to skip down here where it says primary and secondary Parkinsonism, and primary Parkinsonism is going to begin after the age of 40, and it is prevalent more in males, and it is the motor disorder itself. There's nothing else going on regarding the person's health except for this. With secondary Parkinsonism, this means that it was caused by a disorder other than Parkinson's disease. Maybe there was a head trauma, an infection, a tumor, atherosclerosis, toxins, or some type of drug intoxication that brought on this Parkinsonism. So the good news with this one is that it is reversible. So when we think about the pathophysiology, and you could see this pictured over here, we can have two different things kind of lead into PD. So it could be oxidative stress, mitochondrial dysfunction, and a loss of nerve growth factors, which then can lead to a nigrostriatal dopaminergic neurodegeneration within the basal ganglia. We may also have a genetic predisposition to this, in which we start to form Lewy bodies within the residual neurons, and there's a protein that starts misfolding here that can also lead to this degeneration within the basal ganglia. Now later on you could see that this can cause Lewy body dementia, but this tends to take place if the person lives to 70 years old or longer. So going back to these two causes that are leading to the degeneration of our basal ganglia, then we start to have a dopamine deficiency, and that is a loss of our normal inhibition of muscle tone, because dopamine is an inhibitory neurotransmitter here. And we could see that loss taking place here in the midbrain. So here's a person that has everything kind of intact. Here's the substantia nigra, and the black here is really representing that dopamine is there, it's being released by the neurons. Whereas here in someone that has Parkinson's, you don't see that black color over here, noting the deficiency. So with this, we also have an unopposed cholinergic activity that is promoting muscle tone. And so this starts to develop a resting tremor, rigidity, and bradykinesia. So essentially what's going on here is hypertonia, really referring to the rigidity and the tremor, and then the hypokinesia. And so this abnormal movement that starts to take place is known as Parkinsonism. It's also been talked about as Parkinson's syndrome or Parkinsonian syndrome, or paralysis agitans. We'll see that there are some postural disturbances. So you could see more of this stooped type of posture that they have. They're essentially trying to make sure that they are going to not fall over. They have that slow movement and poor balance. They also experience autonomic and neuroendocrine symptoms, such as inappropriate diaphoresis, orthostatic hypotension, some drooling going on. They may have some gastric retention, constipation, and urinary retention as well. And there's some cognitive affective symptoms. And in order to diagnose one with Parkinson's, you would need their history and see these clinical features, especially having these short shuffling steps. Even when they're turning around, they kind of shuffle to turn the other way. And to treat it, you would basically look at the symptoms and kind of treat those. You could do this with drug therapy in order to decrease the dyskinesia. Deep brain stimulation has also been used, and there's some experimentation in which they're implanting stem cells and fetal cells, as well as utilizing gene therapy. Next, we're going to get into our motor neuron syndromes. First, we'll talk about the upper motor neuron syndromes, and this is a result of some type of injury to the motor pathways that are descending from the motor cortex. So this area is representing our motor cortex here. And what we tend to see here is paresis, or a type of weakness that takes place. That's more of a partial paralysis with incomplete loss of the muscle's power. And then we can have paralysis take place as well, which is a loss of the motor function of that muscle group. It's unable to overcome gravity. And so we have these different injuries that can take place, and you see them listed over here as far as different types. We'll get into that in just a second. But initially, we're going to start to see a flaccid paralysis, but then within a few weeks, we'll see a gradual return of that motor function that is going to be overactive. And that's going to include excessive, regular occurring movements such as clonus, which is that rhythmic contraction that we mentioned when we were talking about seizures, and we'll also have spasms taking place. And this essentially is because we have a loss of the descending inhibitory control. So first, let's talk about hemiparesis or hemiplegia. And this is when we have a partial paralysis or full paralysis of the upper and lower extremities on one side. So you can see this demonstrated here with the hemiplegia drawing. Then we have diplegia, and this is a paralysis of the corresponding parts of both sides of the body due to a cerebral hemisphere injury. So here we see it's taking place in the lower limbs. And then we have paraparesis and paraplegia. And this is when we have a weakness or a paralysis of the lower extremities as a result of the lower spinal cord injury. That could be depicted like we see here too. And then we have quadriparesis or quadriplegia, where we have a weakness, I should say partial paralysis or weakness, or a complete paralysis of all four extremities as a result of a upper spinal cord injury. And one more thing I want you to note that is if the injury takes place above the level of the pons, then we're going to see that the hand and arm muscles are more greatly affected. Next up, we have our lower motor neuron syndromes, and this is a result of injury to the alpha motor neurons. So just to refresh your memory, when we have the upper motor neurons move down through the spinal cord, they are going to kind of get to the spinal cord level that they need, and then they are going to make their way over to the muscle in order to send the impulse through and cause the muscle to contract. So these are pretty big neurons here, and we can also find them in the area of the anterior horn traveling over to the muscles. These can be spinal nerves, but they can also be cranial nerves that are going to cause a muscle to contract. For example, cranial nerve number 11 going to something like the trapezius. So when we have this type of syndrome, there could be damage that takes place at the anterior or ventral horn. It could take place at the ventral root. It could take place at the spinal nerve. It can affect the plexus or the peripheral nerve itself, something like the musculocutaneous nerve or the femoral nerve and so forth. And when this happens, it can impair both voluntary and involuntary movement in the muscles that are innervated with the involved nerves that I was just mentioning as an example. Now, because we are cutting off that nerve supply to that muscle, this can cause flaccid paresis or paralysis, depending on how many motor units are affected. And we're also going to have these gamma efferent fibers affected as well that are depending on information from the muscle spindles here in the muscle to go back and communicate sensory information from the skeletal muscle. So what these gamma neurons are helping do is maintaining the muscle tone and assisting with normal motor movement. So when that is affected as well, what we're going to end up with are reduced tendon reflexes, which can cause hyporeflexia. And because, again, we're not getting that feedback from the muscle spindles, we will also get some reduced tone to the muscle, which you already know as hypotonia. And so over time, we will start to see that the muscle will atrophy or shrink over weeks or months because we're not using it anymore. And what we can have happen is a demonstration of fasciculations. And that is when we get muscle rippling or quivering under the skin. And then this is more rare, but we also can have some fibrillation take place where we get isolated contraction of a single muscle fiber because there's some metabolic changes in this muscle that is no longer receiving nerve input, but we can't really see that clinically. And then on the right here, we just have a summary of the motor function syndromes based on the disturbances that are classified pathologically along the upper motor neuron structures and the lower motor neuron structures. There can also be progressive degeneration of both the upper and lower motor neurons. We'll start with facial nerve or Bell palsy, which you could see pictured over here. This is when we have a acute unilateral lower motor neuron paralysis of cranial nerve number 7, where we are going to remember that the facial nerve is supplying the muscles of facial expression. So under this condition, we are going to see that the forehead doesn't wrinkle, the eyeball is going to roll up, the eyelid is not closing, and we've got a flat nasolabial fold and paralysis of the lower face muscles, where we're going to have an inability to smile or be able to whistle. And the cause of this is actually unknown, but we have a sense that there's some type of inflammatory reaction that compresses the facial nerve. There can also be a demyelination of the neuron as well. And they have found that within 78% of the cases that there was a reactivation of the herpes virus within the facial nerve or within the geniculate ganglia, or it was an autoimmune response. And there was also a reactivation of the herpes zoster within 30% of the cases. Now, in some rare instances, there can be a reactivation of the herpes zoster virus, and this is known as Ramsay-Hunt syndrome. And if you remember, this is what Justin Bieber suffered from. So it is rare and you can recover. And for both of these disorders, there can be a use of antivirals or oral steroids to recover. Next up, we have Guillain-Barré, or Barré, I think is how most of us pronounce it, syndrome. This is a rare demyelinating disorder that is typically caused by the humoral and the cell-mediated immune system, and it attacks the peripheral nerves of our body. Typically, it takes place after a respiratory tract or gastrointestinal infection, and we see some of the manifestations here. It can cause tingling or weakness to paralysis in the legs or complete quadriplegia. We can also have respiratory insufficiency and autonomic nervous system instability as well. Next up, we have spinal muscular atrophy, and you can see that pictured over here because within SMA, it's an inherited autosomal recessive degenerative disease that's affecting the anterior horn or ventral horn cells of the spinal cord. And we know that that's where the cell bodies of our motor neurons live. So we're going to see that there's weakness and atrophy of the skeletal muscles. Then we have our bulbar palsies. So I'm going to kind of do the progressive and just the regular bulbar palsy together. Interestingly enough, progressive, I feel like it should involve more cranial nerves, but it's really bulbar palsy that has more cranial nerves affected. So the word bulbar was used because that's what they used to call the medulla. So all the cranial nerves that are originating from the medulla, such as cranial nerves 9, 10, 11, and 12, which are glossopharyngeal, vagus, accessory, and hypoglossal, are affected here. And so if you just think about some of their functioning, you can get an idea of what the clinical manifestations are going to be. Here we see in progressive bulbar palsy, we are going to have paresis or paralysis of the jaw, the face, the pharynx, and even the tongue musculature. And that can lead to things like aspiration or malnutrition, possible dehydration if they don't have the ability to intake fluid, and an inability to communicate verbally because of the effects of the motor to the tongue and the hypoglossal cranial nerve. Next up, we're going to elaborate on ALS a little bit more. This is a neurodegenerative disorder involving both the upper and lower motor neurons, and the name really references this. So when we see amyotropic, that's referring to us not getting enough muscle nutrition or having progressive muscle wasting taking place. And that is because the lower motor neurons are really affected here. Remember that they're going to go and send the impulse over to the muscle to tell it to contract. So that when that impulse is not happening, the muscle starts to atrophy. And then we've got the lateral sclerosis portion of it. And this is referencing the upper motor neurons because we get a scarring that takes place of the pyramidal or corticospinal tract. And if I go back to this previous slide here, you can see that corticospinal tract in the green. So remember that these are basically a bunch of neurons kind of bunched up together, and this is sitting within the lateral column of the spinal cord. So this can start happening within the 4th decade of life, but tends to occur more between the ages of 60 and 69 years old. And we do see it take place in males more than females. Unfortunately, we don't know what causes it, but we are aware of a subset of genetic mutations that can lead to a neurotoxicity of the motor neurons. And even though it's possible to live years, decades with this disorder, such as Stephen Hawking, who is pictured over here, and this was also named after the baseball player Lou Gehrig, so it's sometimes known as Lou Gehrig's disease. People with this diagnosis tend to pass away from it due to respiratory failure, and it's usually within 3 years of that diagnosis. Now, as far as the clinical manifestations, like we said, there is going to be muscle weakness taking place. It starts out in the arms and then the legs, and then it can lead to progressive muscle atrophy. Elsewhere, we get spasticity and loss of manual dexterity and affecting the gait. Also, people with ALS can have progressive bulbar palsy that we just talked about, so that can cause some difficulty within speaking and swallowing. Next up are disorders of posture, and this is when we have inequality of the tone in our muscle groups as a result of our posturing limbs. Now, we've talked about many of these postures or responses already, so I'm going to focus more on the basal ganglion posture, which we briefly talked about when we were looking at Parkinson's, but this is when we have that stooped, hyper-flexed type of posture that is narrow-based, and also they're having that short stepping gait, that shuffling gait that I was kind of pointing out. This is really due to the loss of our normal postural reflexes. So just kind of review these because we've already kind of talked about it. Next up is disorders of gait, and we've got our types of gait associated with neurological disorders listed here. We did talk about our upper motor neuron dysfunction gait, more of a spastic type of gait, where we have injury to the corticospinal system that we saw in those previous slides, because we don't have an accompanying inhibitory control that accounts for these types of gaits. So we can see with mild forms, and you see it pictured over here, that we are going to have that foot drop with fatigue, and they tend to have hip and leg pain. And with our spastic gait, we also have that shuffling gait where they're extending that leg and they're kind of scraping it along the floor in order to move forward. And here we could see our cerebellar or ataxic gait. And this is more of a wide base with the feet spread apart, almost like a tottering type of movement, where we're going to see that the feet are turned a bit outward or inward so that they can have greater stability as they try to walk. Their pelvis is going to be stiff and they stagger when they are walking. This is because we have dysfunction within the cerebellum and we can't really coordinate our gait. Then we've got our basal ganglion gait that we see over here. This is a broad-based gait that the person will utilize small steps and also have decreased arm swing. And the head and the body is in that flexed position. So you might relate this to the Parkinson's type of walk that we have. The arms are semi-flexed here and abducted, whereas the legs are going to be flexed and rigid. And lastly, we have our frontal lobe ataxic gait, and this is associated with the hesitation to start the movement. We have that gait ignition failure, and so they are going to keep that wide-based stance as they're trying to walk, and the body may even sway and fall. They tend to lose control of their trunk pretty easily, and there may be some shuffling or freezing taking place. Now on to disorders of expression. This is going to involve the motor aspect of communication, and first up we have our hypermimesis, and this is when we have a pathologic laughter or crying taking place. The laughter is associated with the right hemisphere type of injury, whereas the crying is associated with the left hemisphere injury. And if we have a hyper, we also have to have a hypomimesis, and this is going to be manifested as a prosody, which is a loss of emotional language, where they may be unable to understand the emotion in speech or people's facial expression, or it's to express emotion in their own speech or facial expression. And this is associated with right hemisphere type of damage. And then we've got our dyspraxia or apraxia, and this is where we have a disorder of a learned, skilled movement with difficulty planning and executing coordinated motor movements. So they have a hard time performing certain tasks that require motor skills, such as speaking and writing, even using utensils to eat their own food, playing certain sports like baseball, football, basketball, and so forth, or following instructions and focusing. And we tend to see this happen when we have damage to the areas from the right and left cortical areas that are interrupted. So in areas such as the corpus callosum. Next, we're going to talk about the extrapyramidal motor syndromes. And we know that the extrapyramidal system is going to encompass all motor pathways except for our pyramidal system. So that is the corticospinal tract that we've been talking about, and the corticobulbar tract as well. So essentially there are two main syndromes here that we're going to talk about, and that is our basal ganglia motor syndrome, which is when we have an imbalance of the dopaminergic and cholinergic activity in the corpus striatum, which, if you remember from A&P, is made up of the caudate nucleus along with the lentiform nucleus, which is our putamen, and the globus pallidus. And this produces a hypokinesia and hypertonia. So that's a lot of the symptoms that we saw within Parkinson's and also Huntington diseases. And then we have our cerebellar motor syndromes, and these are associated with ataxia and other symptoms that are going to deal with coordinated movements and balance. So we see the same side of the body being influenced, so that damage to our right cerebellum is going to cause symptoms on the right side of the body. So that is it. I know that this was a very, very long lecture, but I hope the extra detail helps you understand and commit these to memory.